Good morning, everyone, and welcome to the Introduction to Selective Contracting for County Managers and Staff. My name is Kim Waterman, Project Coordinator for the DMC-ODS Waiver Training Project. We're glad you can join us this morning. We do encourage you to submit your questions at any time during the presentation by typing your question in the questions box in your GoToWebinar control panel. Please note that all attendees are in listen-only mode, but we will break periodically throughout the training to address questions. If you pre-registered, you should have received by email a copy of today's PowerPoint presentation and handout. If you did not receive the materials, you can download them now in the handout section of the GoToWebinar control panel. There will be a brief survey at the end of the session as you exit GoToWebinar, and we thank you in advance for taking a few moments to share your feedback. We do read your comments and use them to inform future trainings. So joining us today by phone is our trainer, Rob Libbey. And I'll go ahead and turn it over to him to begin the training.
Thank you, Kim. Welcome. And Kim, I'd like the slide, I think, to start with that has training description on the top. So what we're going to be talking about this morning is under the Drug Medi-Cal Organized Delivery System, counties are permitted to selectively contract with the providers who are going to be providing services within the ODS on a county basis. And the ODS establishes requirements as well for counties to follow in selecting those contractors. Just generally in outlining the training for today, it kind of breaks into three parts. We're going to talk about the solicitation process, the process that you might use, some helpful hints in terms of what a selection process would look like, and then what the content of the solicitation process should involve. And then finally, probably the last third of the training has to do with the appeals process for denial, so that if a provider is denied in terms of their proposal to provide services, what does that appeals process look like? Next slide, please. So the learning objectives under this is to understand the Drug Medi-Cal Organized Delivery System requirements. And this is really kind of important stuff. You know, the ODS comes down from the federal level. It starts with Health and Human Services, who decided that there would be a continuum of services for substance use disorder patients for the first time, and that's what the ODS is all about. And they turn it over to a federal agency, CMS, the Centers for Medicare and Medi-Cal Services, and they come up with the terms and conditions under which services will be provided. And the terms and conditions become our guidance in terms of how the ODS will eventually work out at the local level. And so what happens is when the state of California, in this case, the Department of Healthcare Services, applies to the federal government to be part of the waiver, they do so by saying that they will implement the terms and conditions that CMS has set forth. When counties contract with the state to be part of the waiver, they also agree to those terms and conditions. Those terms and conditions are then passed on to providers. So it goes all the way down from the feds to the state, the counties to the providers. And so it is important that we know that how this is driven and what those terms and conditions are, and we'll be referring to those throughout the training. And those terms and conditions are all in 42 CFR section 438 if you're interested in doing any research. And I will tell you that as far as, you know, reading fine print, usually we're not too, you know, anxious to read a lot of stuff that's written in CFR, but section 438 is really pretty straightforward in its description of how the ODS should work. Next slide, please. Second learning objective, how to conduct a fair and efficient provider selection process. So we're going to be talking about the options for conducting a provider selection process. Will it be sole source, letter of interest, request for qualifications, request for proposal? How are you going to go about doing it? What are the county's goals? What are the requirements? What does the established county contractor selection process look like now? I mean, counties have their own selection process, and so when you go out looking for an ODS provider, that can be done within the established county contractor selection process. There's really nothing in the ODS requirements that overrides anything, probably doesn't override anything that a county is already doing in their selection process. And then finally, what the county's solicitation documents must include. So when you go out for proposal, what are the state and federal requirements that have to be in those solicitation documents? And it is important that all of these, all of the policies and processes that the county wants to establish for ODS must be in writing. Next slide. So going down to number 3 on this slide, you must have written policies and procedures for selection and retention of providers that are in compliance with DMC-ODS. Okay? The written policies and procedures are important. They're important because in the selection contractor selection process, you of course want to be fair. You want to be clear in terms of what it is that you're requiring of providers, but there is also an appeals process for providers who are not selected, and if you don't have your policies and procedures in writing, then that makes it, you make yourself a bit vulnerable in terms of that appeals process. So all of this has to be in writing. Number 5 on here is important. One of the things that we want to talk about as well is how to keep this process simple, still be in compliance, and still be effective. And it isn't a difficult process. I think for those of you who are involved either at a health services or AOD or one of the county departments that has to do with contracting, you're not going to find this to be a very complex proposal at all. So we'll review all of both the selection process and the solicitation content as well. Next slide. The selection process. Beneficiary access cannot be limited in any way when contractors select providers. Standards for access include. So this access to care is a major part of the ODS, and involved in the selection process. Timeliness is important, geographic distribution of care, that there is a threshold language and cultural competency. Threshold language being the language or languages which are predominant, maybe secondary, tertiary languages in your geographic region. You have to be able to provide information and services in those languages and have staff culturally competent in those areas. Must be physical access for disabled beneficiaries, and a coordination of physical and mental health services at the provider level. And finally, you have to be able to provide assessment and we'll talk about this later, but assessment in the way that the ODS requires. Next slide, selection process. Number 2, your services have to remain at the same level or expand. So when you're looking for providers, you outline your services so that you're not going to come up with services less than what's at the current level. They should probably be expanded because under the ODS, you're going to be opening up services for a wider group of people and opening up more services. You must have written policies. This comes up again, written policies and procedures for selection and retention. that are in compliance with the terms and conditions and Section 438, see Attachment 1. Attachment 1 that's referred to on these slides is the handout that Kim referred to in the beginning that is also that was also made available to you along with the slides. It's entitled Selective Contracting Required Elements of Provider Selection and Termination Policies and Procedures. So attachment 1 is referred to a couple of times in these slides, and what you do want to do when you have a moment, it may not be while we're doing this presentation, you should take a look at the selective contracting document, because it sort of lays out pretty clearly how these written policies and procedures for selection and retention need to look. 4, apply those policies and procedures equally to all providers regardless of public, private, for-profit, nonprofit status. So when you go out to bid, everybody's got a shot at being a provider. If you go out to an open bid, their status as to whether or not they're for-profit, nonprofit, public, private should not enter into the equation. You may contract with providers in another state if you need to do that, and I think that's probably highly unlikely, but that's allowable. Counties may contract individually with licensed LPHAs to provide services in the network. So beyond just contracting with providers, that is with programs with full providers, if you have services that are going to be handled, I think we're really probably talking about case management here, that counties can contract individually with people to help develop the network, do case management, that sort of thing. And then finally, in the selection process, you must not discriminate in the selection, reimbursement, and indemnification of any provider. You don't have to, and while you can't discriminate in selection, reimbursement, and indemnification of any provider, you don't have to contract beyond what your need is. And what they mean by that is, if you decide in your county you need 50 residential beds, that's what you go out for in your selection process, as you're looking for that equivalence. You're looking for providers that can do it. You don't have to open up your selection process to anything more than what you've established as a need. So there's a third program that comes on, say, another provider that says, look, we also have residential beds, and why can't we be part of the ODS? Why can't we advertise our services for taking Medi-Cal and contract with you for that? You don't need to do that. You don't need to contract beyond what you have established as need is. Right? You can limit the size of the contract or contracts. You can use different rates with different providers where that can be justified. And you can establish quality and cost containment rules and regulations that go beyond ODS if you choose to do that. Right? You're not precluded from going beyond what the selection process calls for in your county if you wish to do that. So if you have cost containment concerns that you want to put in a contract, you're certainly allowed to do that. Next slide. Across the top is county requirements and considerations. So these are issues that you as a county may want to be thinking about in terms of how you're going to go about the selection process. Are you going to sole source? Are you going to do a letter of interest, an RFQ, or request for qualifications, or RFP? Which process do you want to use? Those are things that the ODS is not going to control for you. These are matters that you need to look at in terms of how are we going to get the right providers and be able to justify that these are the right providers. What I would suggest I'm not actually supposed to be making suggestions on things like this, but I think that when you're looking for service providers for something as complex as the services, and with the number of requirements that ODS does have for the various services that we'd be asking of providers, that the RFP is probably the best and safest way to go. There's a lot of requirements that providers need to meet under the ODS, and an RFQ is not going to give you enough information on providers really to be able to help you decide who the best providers are if you have multiple people applying. So I would suggest RFP for that, but that's something that counties need to consider. What are your county requirements in terms of dollar threshold, for example, or sole source requirements? And I think that if you are in the AOD area of your county or health services, you are probably already very familiar with what the counties, if it's the purchasing department or in some smaller counties, it's county council, whoever it is that has the policies and procedures for contracting generally, you're going to be staying within those. So you want to be thinking about what are those requirements. As indicated here, is there a dollar threshold for solicitation or sole source requirements? A lot of counties are going to have limitations on when you can sole source, for example. If a contract is for $30,000 or less, you might be able to sole source it. If it's $30,000 or more, you have to go to something like an RFP. So those are issues within the county that I'm sure you're familiar with, but if you're not, you should be familiar with those as you approach the solicitation under ODS. Clarify the roles and relationships between county AOD, county purchasing, if purchasing department is the department within your county that manages contracting. Then are there any conflicts between what your county requirements are and what the DMC CMS requirements are? And I would indicate to you that there are probably very few. There might be something like, they indicate here, low bid. Some counties will say that you have to go with the low bid provider. Under DHCS CMS requirements, we're really looking for quality and not so much low bid. And then next slide, number 5, the county goals amending drug Medi-Cal organized delivery system services into the contracts of existing county contractors who meet drug Medi-Cal ODS requirements, selecting new providers, or screening out programs performing below acceptable standards. I think what we're really saying here is that this is an opportunity to do something different in your selection process. If you have been, for example, contracting with the same organizations for many years and those are all excellent providers and you have no issues whatsoever with them continuing on, and it looks like they can handle the additional requirements of the ODS and they can handle the census requirements of the ODS, whatever your estimated census is going to be. That's fine. If you have providers that maybe you're not so clear that they are providing the services at the level that you would really like to see, you're not so clear that they're going to be able to step up to meet some of the newer requirements of the ODS, it might be this is an opportunity to go out to bid on all of those services. So that's something to think about. To use this as an opportunity just to screen out programs performing below acceptable standards, I think is a little bit dangerous. I think if you feel that you have a provider or providers that have not been doing what they need to be doing and are not performing at acceptable standards, you should probably deal with that as a separate issue rather than try to use this as an opportunity to displace a single program. Next slide. County requirements and considerations. Number 6, keeping it simple. What do you really need to know about a provider to make a good selection? And with all of the requirements in the selection process, can we break this down to think about what we are really looking for? And I think, you know, you're looking for a provider that can give you under A here a plan for meeting the key elements of the DMC-ODS terms and conditions. Right? So you're looking for in the responses to a solicitation, you're looking for programs that can meet the key elements and can show you how they're going to meet the key elements, that they have a plan for that, both an assurance and a plan. In other words, when your requirement and your request for information in terms of, you know, how are you going to provide immediate access for treatment, and you say that's a requirement, and the response comes back, we will do that. You know, we will provide immediate access for treatment, is really not good enough. You want programs that have an assurance and a plan. How are you going to do that? How are you going to meet the key elements? Is really what you're looking for, but nothing really so much more than that. You're looking for documentation of fiscal stability, so you're looking for programs that have a history of being strong financially, and programs that are going to be able to show you on a line item basis that they're able to justify their unit of service rate, so they're able to provide you with a budget that says this is how our budget breaks out, this is how we're going to be able to sustain ourselves financially on the unit of service rates that we have. But that's not going to pop up as an issue later for you, that they're not able to sustain themselves based on what the unit of service is. And then 7, selection criteria. How can you incorporate what county staff already know about a proposer? You know, how do you go about doing that? I mean, you already probably know a lot about programs in your counties through prior contract performance, their fiscal stability, quality of their relationships with other providers. How do you use that information? And I think it's important to do that you have something in your selection process beyond what their written responses are that allow you to use what county staff already know about your providers. And next slide. Number 8 has to do with contract negotiations, and this is after a selection. You should, in your contract negotiations, address in your contracting process where there's areas of weakness in an otherwise good proposal, which may require specific action for remediation. So you've already gone through the selection process. You've selected a program that is pretty strong. They've been strong in most areas of their responses, but there may be some areas of weakness as well. Those should be looked at in terms of contract negotiations to get the programs to firm up any weak areas, and then B, if there are questions about staffing patterns, staff productivity, staff qualifications, and those kinds of issues, if there are any questions about those should be dealt with in contract negotiations as well. And number 9, process considerations of the county chain of command, frequency and types of communication with higher ups, provide recommendations to the board prior to announcing review committee results. This probably differs from county to county. And what number 9 here really is trying to do, I think, is to get people to think about as part of the process, as you are going through your selection process, that you are bouncing off your sort of concerns and your recommendations to other people who are involved in the process, so that there are no surprises at the end, so that you're not handing the board of directors your list of contractors that you've already selected without discussing that with anyone else along the way, so that if there are considerations, and there may be some very strong considerations by people who are, quote, higher ups, that they've had an opportunity to opine on your selection process and who you have selected. I just wanted to remind you, I'm not able to see questions coming in. Kim can, so I don't know if there are questions at this point. If there are, Kim can let me know. If not, I did want to remind you that you have that opportunity to ask questions as we go. Kim, are there any questions?
Not at this time, Rod.
Okay, good. Maybe that means I'm talking too fast.
There you go.
So next slide, on denials. Within the terms and conditions, there are opportunities for denials, and there are certain requirements for denials. The county shall have a protest procedure for providers that are not awarded a contract, and it says again, see attachment 1. And I would direct you, when you have a chance to look at attachment 1, to look at the second page. And sort of the whole middle section of that page goes through a thing called the bidder appeals process. And it talks about what the appeals process needs to look like, so that if there is a denial, that bidders are very clear on what they need to do. So the county protest, number 2, any solicitation document utilized by counties for the selection of DMC must include a protest provision. And it shall have in it, if you drop down really quickly to number 4, it shall have included in it the requirements outlined in the state and county contract. See attachment 1 again. So you have to actually put in the proposal document, in the solicitation document, what the protest process is, so that people know there is a process and what that is right from the get-go. And then number 3, counties shall serve providers that apply to be a contract provider but are not selected with a written decision, including the basis for denial. So it's part of this process. Once you've made your decisions on selection, you need to let people know in writing that they were not selected. Next slide. Under denials, number 5, providers that submit a bid to a contract provider but are not selected must exhaust the county's protest procedure if a provider wishes to challenge the denial of the Department of Health Care Services. So there is, this is just kind of detailed information. It's pretty straightforward, but I think we need to go through it, and I'll try to make it as quick and painless as possible. So there, if a provider is not selected, they have to go through this whole protest procedure before they can go to the state. They can't go directly to the state. And if so, they go to the county, and the county has 30 days to render a decision on their protest. If they don't render a decision at all within 30 days, that's the same as denying the protest. And then the Department of Health Care Services also has their appeal process, and the providers may then go, after that 30 days or after being turned down by the county, they can then go to the state. And if you go to the Department of Health Care Services website, you can get all this information on attachment Y. But on the next slide, if we go to the next slide, we can talk a little bit about what is in attachment Y, and it's the detailed information about the appeals process. So once the county protest procedure has been followed, the provider can go to the state and they have to be able to show that they meet all of the objective qualifications that were required in the solicitation document, and they have reason to believe the county has an inadequate network of providers. So what they're saying is they don't have enough or the right providers, and we would have been a better selection for that, but they need our services somehow. They have to be able to show they're capable of providing those high-quality services under the current rates, and they can demonstrate arbitrary or inappropriate county fiscal limitations, and then finally can demonstrate that the contract was denied for reasons unrelated to the quality of the provider network adequacy, so that they may feel that they have been shorted in the process for some other reason, that the county maybe has a negative attitude about the program and turned them down for that reason, and it was unfair, etc. Next slide. Under 3, DHS does not have the authority to enforce state or federal equal employment opportunity laws. So if a protest has anything to do with equal opportunity laws, then that has to be dealt with through the normal processes for that. You have to go through the state, EEOC, whatever the appropriate federal and state equal employment opportunity law agencies are to protest that. So if the protest has to do with those things, the DHC is not going to deal with that. So the provider then has 30 calendar days from the conclusion of the county protest to submit an appeal. So you got 30 days once the county turns you down to put in the appeal to DHCS. Next slide. Number 5 here, the provider then shall include the following documents to DHS for consideration of appeal. And I think this is why a lot of appeals probably never make it to the state level. It really requires a fair amount of documentation in order to get an appeal lodged appropriately. The packet would have to include the county solicitation document, so the document that the county used to go out for bids, the provider's response to that document, so whatever your bid was, the county's written decision not to contract with you would be included in it, and any documentation you used and submitted to the county as part of your protest has to be included, as well as the written decision back from the county, if there is a written decision. Remember, if the county's got 30 days if they don't respond at all, it's the same as a denial. And then any evidence you have supporting the basis of your appeal. So there's a fair amount of information that one needs to pull together and get to DHCS in order to launch your protest with them. And then finally, on the next slide, under 6, the county then has 10 working days from the time they know that a provider has submitted a protest. They have 10 working days from that date in order to submit their documentation to DHCS. Right? And the county then has to include in theirs the qualification selection procedures, all of the data that the county has used to determine how many people need to be served under a particular program, the one that's being protested, for example. Or, if you decided you need 50 residential beds in your county, then you have to be able to come up with the data that, how did you determine that you need those 50 beds? If the protest maybe is from a provider that wants to say you need 75. See the basis for asserting that the appealing provider should not have been awarded the contract based on the county solicitation procedures, that the county fails somehow to meet these solicitation requirements, the kinds of things that we've been talking about this morning. And then on the next slide, within 10 calendar days of receiving the county response, the state responds to that. They do an arbitration, where they bring the parties together and make their determination as to whether they will accept the protest or not. And when they make a determination, it is final, right? Taking a look at the next slide, number 9. And number 9 is kind of important. Following the department, the DHCS's determination that the county must take further action if they feel that the county was indeed at fault, there will be a corrective action plan. The county has to go back and fix whatever it is within their solicitation process or whatever it is that has kept this provider who has protested out. And it must deal how and when the county will follow its solicitation procedure to remedy those issues. And then the punishment can be kind of tough. It says DHCS may remove the county from participating in the waiver if the cap is not promptly implemented. So if DHCS in its review decides that there is an issue with the county has to respond to that quickly and improve it. It might be something like going back out to starting the whole process over again. It kind of depends on what the protest is about, but they will insist that it needs to be fixed. And 10, the decision issued by DHS shall be final and not appealable. So whatever happens at the end of this, if the protest goes through the county and it finally goes to the state and the state makes a judgment on it, then that's it. There will not be any further. It does not go to go to CMS to the federal level. That's the end of the road. Next slide, please.
Hey, Red, we actually did have a question come in.
Okay.
This person asks, our county's protest process from beginning to end is 33 business days. How will our policy work if you are saying we must render our decision within 30 calendar days?
Could you read that again, please?
Sure. Our county's protest process from beginning to end is 33 business days. How will our policy work if you are saying that we must render a decision within 30 calendar days? And I think this was based on one of the denial slides a few slides back. It says providers that submit a bid to be a contract provider but are not selected must exhaust the county's protest procedure. This is the county does not render a decision within 30 calendar days after the protest is filed with the county. The protest shall be deemed denied.
I will refer that question to DHCS. I'll tell you what my opinion is, but I don't want to not provide an absolutely accurate answer to one of these questions, and I am thinking that regardless of what the county's normal process would be, if it's 33 days, if the state says 30 days regarding these, it's probably 30 days for these. It may be an exception where the county has to make an exception. It has to be 30 days. However, I think you need to contact, the person asking the question needs to contact DHCS. It's a very legitimate question, and just say, hey, this is what we learned. This is what it says in your documentation. Is 30 days normally? Is 33 for us? Is that going to be an issue or not if ours is 33? You'll be able to get a pretty straightforward answer on that. And I don't think I should probably offer an opinion on that. I think there's a yes or no answer to it. Okay?
All right. Thanks, Rod.
Is that it?
That's it at the moment.
Okay. So the slide that we're on now is county considerations for denials. Selection processes are most often overturned on process flaws and not content flaws, and I think that's absolutely true. When someone protests, it's usually about, X program was given this information, we were not given the same information, right? There was a bidders conference, but the notes of the bidders conference were not accurate, for example. It's something in the process of going out to bid that's usually protested. It's not the content of the information, okay? Content would be something like we are asking for, you know, license, that one staff have a certain LPHA level license in a particular program. That's pretty straightforward. You either have that or you don't. But when people feel that they have a real consideration, it usually has to do with what the process was. So how do you avoid those common process flaws? The big one is equal access to communication among proposers, a centralized point of county contact. So this is true of any bid, by the way. It's not just true of ODS, but I mean, this really addresses what is the, you know, the right process in going out to bid. That everybody has the same access to communication among proposers. So there's a centralized point of county contact. You identify somebody within AOD or within behavioral health or however your county is set up, and that's the one person that you can send questions to or call and ask questions of that can give you an answer, and that you're sure you're talking to the rest of your staff, saying when somebody calls you from a program in the county has a question about the bid, refer them to this one person. Don't try to answer questions. You have 5 people within behavioral health all answering questions in a slightly different way. That's what leaves it open to the process flaws. So-and-so told me I could do it this way. That there is a bidders conference, and that that's well publicized. Everybody knows that there's a bidders conference and can go to that bidders conference. There should be minutes of the bidders conference, and they should be detailed. So, and the questions that are asked at the bidders conference are part of those minutes. Limit informal communication. Again, make sure there's just one person that you're going to. And then if there is something that comes up, a good question that comes in that hasn't been covered in the information that you've put out, that one proposer brings up, be sure that goes back out to all of the other proposers so that everybody's getting the same information. Clear submission procedures and deadlines. Who do you send it to? In what form do you send it? You know, you can email it, you can scan it in, or you have to send in within 48 hours of that period of time, you got to send in, your hard copy document, whatever it's going to be, and what the deadlines are need to be very clear. Put your scoring instrument in the solicitation document. So be very open about how the document's going to be scored. Your answer to question number 1 will get 10 points. Your answer to question number 2 is 20 points, whatever that's going to be, so that everybody is clear about how their proposals are going to be rated, and what are the important parts of those solicitation questions. And then put your selection process and appeals process in the selection document. And that actually is required, that you put in when you go out to bid in that solicitation document, that you talk about what the selection process is going to be and what the appeals process is going to be. And I think we already talked about there's a section in attachment Y, I believe, that has to be included in the solicitation document itself. Next slide. County considerations for denials. Choosing your selection committee. Make sure you have good content area experts. People with no perceived appearance of bias or perceived conflict of interest, so that somebody's brother-in-law of a treatment provider is not on the committee. So no appearance of bias or perceived conflicts of interest, no communication by selection committee members with proposers. So you definitely do not want people that are going to be part of your selection committee to be talking with proposers at all about the solicitation, and be sure that there is diversity on the committee that reflects the community. I think those are all pretty standard kinds of things. F, managing the selection committee meeting. I have a little bit of a disagreement on this one. By the way, these are slides and presentations. This particular one was written by someone else, and it's approved by the state Department of Healthcare Services before it's presented, and so the slide is approved. I would personally differ a little bit with F. It says, managing the selection committee meeting score in pencil with an opportunity to change scores as a result of discussion among the selection panel members. Turn in scoring sheets, keep written minutes reflecting consensus, keep in mind what is discoverable in a lawsuit. I think that you may differ on that. You're county to county, you may differ a little bit on managing the selection committee. Are you going to score them in pencil, which would mean that after people separately score a proposal, that they would get together and talk about it, and they may want to change their scores. You may or may not agree with that as being the appropriate way to proceed. So this is just a suggestion that the writer makes on this, and I think that would really be more something that would be decided by folks on a county-by-county basis. The last one, it says, keep in mind what is discoverable in a lawsuit. Everything is discoverable in a lawsuit. So I think that whatever your process is going to be, outline it, make it very clear, and don't deviate from it. Next slide, solicitation content. Content requirements from terms and conditions in section 438. So this is, now we're sort of moving to what, in the solicitation document that goes out, we're talking about what is the content of that, what actually has to be in that. Pretty much up until now, we've been talking about what the process is going to be in terms of going out to bid, looking at those proposals, evaluating those proposals, and dealing with denials on those proposals. But now we're talking about the content of the solicitation document. Number one, require providers to meet DHCS standards for timely access to care, from initial contact to face-to-face appointment, timeliness of access after hours. For after-hours urgent emergency care must be equivalent to non-DMC services offered by the provider. So the issue that you find, that providers will find with the county's ODS plan and what the counties found in the state's DHCS plan is that one of the big changes under ODS is timely access to care. In the past, there is wide use of I guess you would call them sort of wait lists and ways of sort of dealing with the census of people, or people coming into programs where you can't meet the existing census requirements. And it usually results in things like wait lists. And the ODS requirements pretty much ban wait lists. They want there to be a process in which people, they probably would call it treatment on demand, a phrase that I don't like particularly because we can never quite get there to providing treatment on demand. But they want us to smooth out and improve the process of intakes, admissions, and getting people from the point at which they first ask for care until they get a face-to-face appointment. And this, by the way, goes all the way back up to the feds. This is something that comes out of CMS. I mean, there are certain things in the ODS that are really important. There are things that the feds have promised in spending this huge amount of Medi-Cal money to cover the ODS. They said, we're going to improve care. And this is one of the ways we're going to do it, is that people are going to get more immediate access to care. So at some point, that's going to be part of your evaluation, right? As a county and a provider's evaluation, are you doing this? Are you getting, what is the length of time from the time people call until they actually get a face-to-face appointment? You're going to have to track that. So this is important stuff. So you have to be able to meet all of these kinds of requirements having to do with access to care. I would suggest that if you haven't taken the quality assurance, CIBHS has a training on quality assurance, and it's something that you might want to consider taking. If you haven't, it gets a lot more into the details about what are the standards around quality issues, and you know, time from first contact to face-to-face appointment. The details of that are in that training. But the details of that also have to go into your proposals, so people know when they're responding. When you have a provider out there who's responding, they need to know what is that. It happens to be 7 days, but you know, they need to know exactly how fast they're going to have to be able to see people and what the rules are around intake. You must not discriminate against persons who require high risk or specialized services, that is, like co-occurring disorders or culturally specific services. You must select providers that have only a license or certification issued by the state that's in good standing. So you want to have in your solicitation document that they have to be able to provide that to you, you know, being on a waiting list to have your drug Medi-Cal certification approved is not good enough. I mean, to have licensure or certification pending doesn't work. To have your licensure or certification temporarily suspended does not work. You have to have it in good standing, of course. Next slide. You should select only providers that prior to the furnishing of services have enrolled with or revalidated their current enrollment at a high categorical risk. You can sort of take number 4 and it looks very complicated, and it sort of is, but just forget about it. High categorical risk, what it means essentially is that if you are drug Medi-Cal certified, and in order to be part of ODS, your programs have to be drug Medi-Cal certified. If they're certified at a high categorical risk. There is, I think, modified and limited and high categorical risk. There's 3 different categories of risk, and it has to do with how detailed the review of a program is to measure its whether or not they're approved at this categorical risk. And high categorical risk means that you have satisfied all of the requirements under certification, up to and including things like the key staff have been have had background checks and been fingerprinted and all that sort of thing. But anyway, if you reach the certification, DMC certification level, then you're fine under high categorical risk. Number 5, no selection of providers who are under investigation for Medi-Cal fraud. Ask a provider to attest to not being under investigation. Does DHS notify counties when a provider is under investigation? I would ask you that question if we were doing this face-to-face. It's sort of an interesting discussion. They do not necessarily notify you of that. When DHS has a provider under investigation, it's not always to their benefit to let anybody know that an investigation is going on. So you may not know if a provider who's applying is under investigation or not. You can ask, but you may not get a clear answer on that, and you can't get a very clear answer on it. But before you sign a contract with the provider, once you've gone through your whole process and you've made your selection, you should definitely check with DHCS to be sure that the provider is not under, and they would tell you at that point if there is someone under, if you shouldn't, if they feel that you should not contract with the provider. Next slide, number 6. Has to do with medical directors. The programs do have to have medical directors. It's something that may be new to a lot of providers under ODS. and it gives you here the sort of requirements that the medical director needs to meet. They have to be at limited categorical risk, and they have to have received that rating within a year of this application. Okay. Let's see. So next slide, solicitation content number 7. All contracts with providers must include the following provider requirements. Services furnished to beneficiaries by the provider in this amendment are safe, efficient, effective, and patient-centered, timely, culturally competent, efficient, equitable, and as defined by the Institute of Medicine. And these are some of the quality standards that must be part of the solicitation. Patient-centered care as defined by the Institute of Medicine. I have to admit, when I first saw this, that while I always have felt that I know what patient-centered care is, and I still think I always have known what patient-centered care is, I did not know that it was something that was defined by the Institute of Medicine. I didn't know there was such a thing as the Institute of Medicine. But for your information, since I had to look it up and learn what it said, it basically patient-centered care, according to the Institute of Medicine, is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values go into all decisions. That's what patient-centered care is. It's very specific, according to the Institute of Medicine. They possess the necessary license, again, that they have the necessary license and certification, and maintain a safe facility by adhering to state licensing and certification regulations. So again, if you're licensed and certified, you're going to provide copies of your licensure and certification. That sort of covers all of those issues about safety. And then we get into client records, that you got to maintain client records in a manner that meets state and federal standards. And we're not talking about those here and getting into any detail here, but you probably, if a provider has, and counties have operated, of course, Medi-Cal programs in the past, so you know what the client records need to look like. And if you have operated, as I'm sure you have in your counties, mental health Medi-Cal records, they are almost identical. So you will know what it is you need to have in order to meet those requirements. And then next slide, to meet the established ASAM criteria for each level of residential care, they provide and receive an ASAM designation. So, and it goes beyond residential care, actually. If you have to have ASAM training prior to providing services. So what you're looking for in your providers who are responding to your solicitation is that if they don't have ASAM training already, that they have a plan to be ASAM trained prior to the implementation of the ODS in your county. Right, that's an absolute must. And again, in this particular training, we're not getting into ASAM criteria and what all that means, but it is the central point of entry into these programs is based on ASAM, and obviously you have to have staff trained in ASAM. It also gets into the whole issue of under the ODS, we're really talking about a continuum of care. We're talking about moving people from program to lesser levels of care when that's indicated, or higher levels of care when that's indicated, and all of that is based on ASAM criteria. So ASAM is a critical piece of the response that you're looking for. And then be sure they meet quality assurance standards and any additional standards established by your county. And that you provide for the appropriate supervision of staff. So I think you're looking for staff supervision, particularly staff supervision of licensed and certified staff. And next slide. Under number 8, provider context must include culturally competent services. That your staff must be trained in providing culturally competent services, that medication-assisted treatment providers will regularly communicate with medication-assisted treatment prescribers, and that the programs will implement at least 2 evidence-based practices. Under the ODS, there is a requirement that your programs implement 2 evidence-based practices. I believe in their documentation it even talks about what are the recommended evidence-based practices, and that's something that you need to have in your solicitation document, and providers have to be able to respond saying that they can do this. And hopefully they will be able to respond saying that they're already doing it. Hopefully they will respond saying they know what an evidence-based practice is. 9, residential treatment providers shall seek county approval of residential treatment admissions, and this may differ from county to county. This is saying you need prior authorization for residential treatment admissions. In some counties, there may be prior authorization required for more than just residential treatment providers as well. I'm assuming there will be in most counties. And then number 10, providers must meet the standards for timely access to care and services. We're back to that point again. There's very specifics on what constitutes timely access to care. And if there were a list of sort of priorities of things that the state and the feds hope for under the ODS, it is that they get good reviews on timely access to care. Next slide. In that solicitation document, and we talked about this before, you have to inform that, well, this is a little bit different. This has to do with informing clients of grievance and complaint procedures. So what you're saying in the solicitation document is that programs have to have a process of informing their clients of grievance and complaint procedures. One of the things that you want to be sure that you specify in the solicitation content, because we're talking about Medi-Cal certified programs, is that we're talking about more than just saying that as a client you have a right to complain to the program. You have a right to complain to your counselor and then to the program manager, etc. If it's a Medi-Cal approved program, as you know, I'm sure already, it's a more specific process that gets to the state fair hearing fairly quickly. So it's a Medi-Cal approved program. If someone is denied services or reduced in the amount of services that they can get, they have an issue in any way with the level of services they're at, or if they've been denied services, they're entitled to a fair hearing if that isn't dealt with immediately at the county level. And you will find that there are programs out there, or providers out there who have operated non-Medi-Cal, like licensed residential care, for example, for years, and they're not required because they're not Medi-Cal certified. They're not required to do the whole fair hearing thing, and may not be familiar with that. So you need to specify that in your solicitation document. 12, comply with county requirements for annual program and financial monitoring. So it's anything else that the county wants in addition to the ODS requirements is fair game, and that should go into the proposal as well, or into the solicitation as well. And finally, and this is one that has been a wake-up call for a lot of programs, and that is the data issue. Providers must agree to meet county, so this is what you're putting in your solicitation content, that the provider must agree to meet county requirements regarding provision of data on appeals and grievances, timeliness of access to care, access to after-hours care, assessment of the beneficiary's experiences or client satisfaction, provision of services in the client's preferred language, and data for the UCLA evaluation of the effectiveness of services. So in the past, data requirements have been fairly minimal in the whole substance use disorder field. There's CalOMS data, and there's data of that sort that's been picked up for years. But now what is required, again, this drops down all the way from the federal level. It's like they are saying, when the feds say, we're going to now put all this Medi-Cal money out there, we're going to do this ODS thing, and we're going to have a continuum of care for people with substance use disorder programs, and they're going to be able to access care in a timely fashion, and it's going to be good care, and it's going to be care that suits their cultural needs, all of those kinds of things. They want the state to look at that. The state wants the counties to look at that. Counties need to have providers being able to maintain that sort of data. That's the only way to show that we are bringing about improvements in care. For a lot of providers, they don't have the infrastructure really to do this, and when you're looking at bids coming in around the data areas, this is really important. And there's going to be some challenges, I think, for programs to be able to collect the data and organize the data in a way that it can be readily looked at. Okay, next slide, programmatic content requirements.
Hey, Rod, if I
yes.
may interject with a question.
Yep.
You spoke earlier about the bidders conference. Would you recommend the bidders conference for RFQ and ROI?
For an RFQ, a bidders conference? Yeah. I mean, I think bidders conferences are an opportunity to bring everybody together and to assure that they're getting the right information. So I think that it would be absolutely mandatory in an RFP, but I think for an RFQ, yeah. Mm-hmm. Sure.
Okay, great. Thank you.
Mm-hmm. There's always a lot
so we're on
Pardon?
Oh, go ahead.
Well, I think that when those of us who would be in administration write a solicitation document and we go over it and over it, and we have all sorts of people looking at it to be sure everything is in there. You go to a bidders conference, and the first 5 questions are extremely good questions about information that isn't clear in the RFP or the RFQ. So I think that they're always very, very useful in terms of being sure that people all have the same information right from the beginning.
Great, thank you.
Okay, so we're now on the slide that says programmatic content requirements. Okay, number 1, have staffing necessary to conduct medical necessity determination. So you have to have LPHAs on staff, or at least one LPHA on staff. And to do the 6-month redeterminations. Once you determine medical necessity, and if somebody is in treatment for a 6-month period of time, then you have to reestablish medical necessity every 6 months. Number 2, provide services consistent. And while, going back to one again, while certified staff are able to handle a lot of the assessment questionnaires and that sort of thing, medical necessity has to be reviewed and conducted by an LPHA, so it does have to be an LPHA in that process of assessing and admitting patients, or otherwise conducting medical necessity. Medical necessity is what's required for people to get into inhaled care. Number 2, provide services consistent with definitions of ASAM levels of service. your programs have to be able to show that they can do that. The ASAM levels of service are documented in a number of different places, and I would recommend there's a document that may be on the CIBHS website, and Kim, if it's not, we may want to talk later about getting this on there for people. There's one called the Assessment of Modalities of Service and Staffing Requirements for DMC-ODS that Bill Manoff wrote. And I think it's a really clear and excellent document in terms of, wait a minute, you know what, I may have given you the wrong title on that. No, that's it, that's the right one. It's a very clear, concise sort of definition of each of the levels of care, each of the ASAM levels of care. And so that might be something that anybody involved in putting a solicitation document together should have that, probably, so that we know what the ASAM levels of service are. And it also, I think, defines what are the what are the levels of care that are required under the ODS. Under the ODS, prevention's required. It's required that a county has a way of doing the 0.5 prevention services, not that it has to go out to bid, but outpatient, intensive outpatient, case management, recovery services, at least one level of residential services in the first year, and 3 levels of residential services within the first 3 years, medication-assisted treatment, and a withdrawal management. One of the 4 levels of withdrawal management have to be provided in the first year by county. So knowing what those are is obviously important, and I'd recommend that document as a sort of a good cogent review of what the required levels of care are. 3, case management and care coordination. This is new stuff in terms of it for substance use disorder to be covered by Medi-Cal, and it may differ a little bit in terms of what you're looking for as you go out for bids. In some cases, counties are doing all of the case management services, and they're not asking for it as part of program proposals. In some cases, their counties are doing some of the case management, programs are doing some of their own case management, and other counties' programs are doing their own case management and all of it, but it is now a separate service, and it can be billed for the first time. And it's really important in the continuum of care. It's really important that case management and care coordination are included so that there are better seamless transitions between the levels of care and the other kinds of programs out there that patients need while they're in substance use disorder care. And I think that's it. I believe that's the last slide. Is it not, Kim?
That's it. Yes.
Okay.
And we don't have any other questions.
No other questions at this time. All right. Good. Well, we're even a little bit ahead of time, so thank you very much for your attention. I hope it was useful.
Yes, and thank you, Rod, for your presentation, and thank you to all of you in the audience for attending. We do encourage you to take a few moments to share your feedback as you exit the session. And with that, we will conclude our broadcast. Have a great day.